All right, good morning, everyone. Thanks so much for joining us for the first webinar in our three-part series focused on revenue cycle improvement. Please take a moment to enter your name and title into the chat box so we know who's joining us today. Today's session will focus on best practices to strategically manage your revenue cycle. While I'm introducing our speaker, Caleb will take a moment to pull up the opening polls. If you don't mind just going ahead and answering those for us. Our speaker for today's session is Amy Graham, Senior Consultant with Stroudwater Associates. Amy is an experienced healthcare executive providing vision and direction in finance and revenue cycle. Amy has over 20 years experience in maximizing the accounting, finance, and revenue cycle processes for healthcare organizations. Her professional expertise includes month-end accounting consolidations for divisions with $50 to $200 million in net revenue, creation of accounting policies and procedures for intercompany transactions, strategic analysis to determine long and short-term organizational goals, development and direction of budgeting and forecasting activities for multiple entities, and understanding of synchronization of revenue cycle management to financial statements. Previously, Amy served as a Senior Vice President of Revenue Cycle Management for the Nashville-based PATH Group, among other positions. Thank you, Amy, for being with us here today. Before we get started, please feel free to chat in any comments or questions throughout the presentation. I'll keep an eye on the chat box and relay those to Amy throughout the session for a more interactive webinar. I'll now turn things over to Amy to get us started. Amy?
Thank you, Shannon. I appreciate it. And thank you all very much for your time this afternoon. I realize it's a Friday, and sometimes revenue cycle is not the topic that everyone wants to talk about on a Friday. Thank you also to the National Rural Health Resource Center for giving me this opportunity, and wanted to just, dig in and dive into it. This project is supported by the Health Resource and Service Administration, HRSA, of the United States Department of Health and Human Services. And it's a part of the Financial Assistance Award totaling over $10 billion, with 100% funded by the HRSA HHS and zero amount and 0% funded by non-government sources. The contents are those of the author and not necessarily represent the official views or endorsement by HRSA, HSS, or the U.S. government. So, digging into the slides, what I want to do is just get on the same page. Let's get on the same page, make sure we're talking about the same language, because sometimes that's where a lot of our challenges occur when looking at managing your revenue cycle team. And then we'll go on from there. So looking at this, many of you may refer to it as billing or coding, but it's a really robust, dynamic process. There are activities that happen in the claim lifecycle. Front-end activities of pre-visit and visit information, which we're going to talk about in our next webinar. And then there are some transaction processing and back-end opportunities as well. And so in thinking about that, you have the front end, transaction processing, and back end, and then it's bookended by two activities, pre-claim activities and analytics. And without pre-claim and analytics, you really do run into some problems with managing your revenue cycle support. And so those are the things we're going to talk about today. And then all of those really provide some foundational support to month-end closing for your facility, cost reporting, which is very impactful between the two, compliance, performance management, and IT and quality. And so we're going to just dive right in and talk about our pre-claim activities. When looking at it, the first thing we're going to start talking about is contract negotiation. And really, these activities happen before the first claim ever happens. It's, you want to know what your patient population is and getting started with that, and who are your major payers in your area. So when talking about the payer contracting life cycle, you've got some pre-work that needs to be done. Looking at, again, who is in your community? Do you have an employer group that has a plan that you're not contracted with, and do you need to have that contract? You want to have an initial meeting with the payer to just express interest in being contracted with them, or maybe have the initial meeting with the payer to say, we are contracted with you, and let's talk about that. How is our contract going? How about an evaluation of your contract? We'll talk about that in a little bit. And then contract negotiations, and then just execution and implementation. And we'll just share some best practices for these different areas. So, in looking at these contracts, you want to evaluate the contract. Is it really competitive? How does it compare to your other hospital payer contracts that are out there? Are you in line? Is this one that they're asking for rates that are much less than your other hospital contracts are out there? What does that look like? You also want to do an assessment of the reimbursement rates. For each of your facilities, you should know what the top 50 CPT codes are by revenue and even by volume, because sometimes you may have the top 50 CPT codes are all lab tests, and the lab tests have a smaller volume of, they have the higher volume, but the smaller amount of revenue on your financial statements. So you want to look at both of those and then assess that against these payer contracts to see, how are they looking at paying for them? You want to review the top 10 DRGs by volume, making sure that they have called those out, that they're not excluded out of the contract, and that you are getting an appropriate reimbursement amount for them. You want to compare it to Medicare reimbursement rates. A lot of times, in my experience, my work came from the lab environment, and they like to pay us less than Medicare rates. But in the hospital setting, you should be paid at a minimum what Medicare is reimbursing you for your cost, because Medicare has established that this is the amount that it should cost to perform these tests and to perform these procedures. And so, how does that compare against those Medicare rates? You also want to compare your contracts against cost-based reimbursement. Medicare has established it, but could it be that you have a department that it's more expensive to provide for? In a lot of our facilities in the rural environment and the rural areas and communities in which we live and work, the cost could be higher than they are in a normal setting, and you want to make sure that your payer contracts are covering for this. And then also look at your Chargemaster. This is one of those areas that, you could get this new contract signed and that will pay you, $600 for the test, but you only have your Chargemaster established at $500. There's a gap there. And how is your payer going to pay you? Is your Chargemaster set up high enough to cover for that? And then with pricing transparency, one of the nice things that's out there, the good thing, if I had to say that there was a good thing that came out of pricing transparency, is that you can compare the reimbursement to other published rates for other hospitals. Or how are they paying you compared to your competitor down the street? Sometimes you may find out that they're actually paying you a whole lot better, and it may make that contract that you're looking at more advantageous. And then you also want to evaluate the remittances. For new contracts, you won't have this information, but for historical contracts that you've already signed and you're looking at renegotiating for, how have they been paying you over the past 6 to 12 months? How is it relative to the reimbursement rates and the contract terms? And then you want to identify and quantify what the top 10 denial reasons are. Have they said they will pay you for these procedures and then you get caught in a prior authorization denial, being they're not paying you after all, even though it was covered under the contract because they're saying it's not authorized? Those are things that you would want to look at when evaluating your payer contracts. And some other best practices. We talked about our payer contracts there and how to evaluate them. But when's the last time you went to look to see if you had all copies of all the pages for your agreement? You sign the agreement in, say, 2017, and then they've done two, maybe even 2011. I've seen that where someone signed a contract in 2011, and then they've done two amendments since then. Do you have all of the contracts, copies, and all the pages out there, the amendments, the most current fee schedule? Are they paying you off of reimbursement rates from when they signed in 2011? Is that what the contract said? Because here's the fee schedule? Or do they update that fee schedule on an annual basis? When looking at the contract itself, you want to pay attention to special clauses. A minute ago, I mentioned that the fee schedule said they'd pay you $600 and then your charge was $500 on the CDM. Is there a clause in the contract that says they're going to pay you the lesser of, meaning the lesser of those two amounts? Or are they going to pay you the $600 no matter what? The other thing you want to look at is price change notification. How far in advance do you have to notify them or do you have to notify them if you are doing changes to your charge master and increasing prices? And what does that look like? How does that communication happen? Those are the things that you're going to want to look at and see and pay attention to. And then the final one, this is for the revenue cycle people that I always speak for them to go, give them a chance to do their work. Look at timely filing deadlines and payment windows. Is the contract established to where claims must be filed within, say, 90 days? So there's a timely filing limit of 90 days, meaning that the revenue cycle team has to get a claim out the door and any appeals out the door within 90 days of that date of service. And yet the payment will come in 120 days. And so what's happened there is that you've actually, you know, hampered your revenue cycle teams, the denials and back end teams who are working those denials from being able to appeal them because they had to get that claim filed in 90 days and they didn't get a payment till 120 days and their opportunity for appealing it has passed. So those are things that you want to keep in mind, just best practices when actually reviewing the contracts themselves. And then some things to remember when talking about payer contracting. With payer contracting, increases to your gross charges don't always fall to the bottom line. So what you're going to want to do is to model the projected impact of CDM price changes per payer and make sure that when you sign this payer contract, what is that financial impact going to be to the bottom line? And then look at the payer contract languages, again, making sure that, you know, excluded services, how are they going to be priced? Clauses that it limit annual percentage rate increases. You're only limited to increase your Chargemaster by your prices by 3% for the year, things like that. And any changes that could trigger those lesser of clauses. And then when looking at renegotiating your existing contract, could it be, it's when you think back, and I'll refer to it again, when you think back to your ninth grade self that went through algebra and you're like solving for X, it could be that you could voluntarily reduce your overall charges to get a higher percentage of charge reimbursement. Take those high volume tests that are low in reimbursement and maybe increase the reimbursement amount, but take those low volume tests and that are high in the reimbursement dollar amount, but maybe lower that because then you're just shifting the scale and solving for X because it could mean that you're getting more money to your bottom line at the end of the day. Or it could be vice versa, where you lower your high volume tests and you increase and letting the payer may think, oh, we're winning in this because we get to lose, we're reducing our overall charges, so we're going to get a higher reimbursement amount and things like that. So those are things that you're going to want to remember when looking at your payer contract. Ways to just leverage the amounts that are coming through and what that looks like and how to proceed with that. Going on to our next topic. So I talked a bit about contract negotiation, but I want to go back and talk about, you know, uh, provider credentialing and EDI and ERA enrollment and how your bank is set up. Now, I want to ask for a minute and say, when do you think the provider credentialing process should start? So typically, is it when the providers are hired for your facility? How many people are involved in the process of getting the initial enrollment with the payers done? Now, I will tell you, this is where I have full transparency. I had to call with a former coworker and really apologize to her because we'd get a provider hired and I'd be like, okay, go and get it updated with Medicare. Go get it updated with the state. It's when I lived in Florida at the time, state of Florida Medicaid. You know, can you get it done? We've given you all the information. Here, go get this provider set up. And she'd always look at me and go, Amy, they know we've got the application. I'm like, well, can you call them and find out where they are? And she'd be like, no, Amy, I can't call. It's going to take 90 days. Be like, no, it's got to be better. It's because we're a little dog. Well, then I went to work for a big shop and I realized that, you know what? That same 90 days in the state of Florida to get it credentialed for that provider, is with the big shop too. It doesn't matter how small or how large you are, it's still going to take between 90 to 180 days to get your provider credentialed at your payer. Now, why am I talking about this? Because Until you get your provider enrolled at the payer, you're not going to be able to bill for the services for that provider. And in some instances, the process doesn't start until the credentialing approval is received. In others, they may backdate it to the date they received the application. So you could have a provider who is hired on January 15, but it could be that you will not receive a single dollar, a single payment for any of the services that they receive until March 15th, if not April 15th, or even July 15th. So, when thinking about that, if you are working and hiring providers, that's when you need to start having the conversations with the people who do the credentialing at the payer. Now, this credentialing with the payers is different from the credentialing at the hospital. So, just keep that in mind, that make sure that you are talking to them as soon as possible, that you have given them all the opportunities they can so that when that provider goes to work on January 15, they can start billing immediately because the payer knows that they are there and you will receive payment for that. The payer will send you notification of enrollment. But then another area that people forget to look at is the EDI enrollment and the banking setup. Be sure that you take into consideration where that payment for that physician services are going to go. Are they going to go to the physician's home address because it's going to go back to the address on their license? Is it going to go to the hospital? But really, it should be going to the lockbox, so that where the payment should be directed. So make sure that you notify the payers, let them know, but then you've also got that banking set up. Because with that banking, we're all about, I mean, just to be honest, I'm all about the money. Where's the money going to go? And you want to make sure that that money and any notification is going to your bank account because that provider is doing work for you. And so, what you want to do is to make sure that you have that. And one of the areas in managing the back end is all of a sudden a provider will drop off. They'll start getting these denials for a provider who's been with you for 10 years. And all of a sudden, what's happened is that someone at the payer side has lost their credentialing information for your provider. And so it's a common occurrence. It happens. And what you can do is just actually work together. This is for the clinics, for your outside practices, your provider based clinics, your hospital providers, all of them to make sure that they are enrolled. Can't stress this enough to just share with people, what the differences that will occur if you have an engaged process, and that the people who are doing the hiring and getting that initial paperwork completed, are communicating with your revenue cycle time team to get the information there. And then the next item, so that talks about prayer credentialing, EDI enrollment, and your banking setup to make sure that that is covered. And now what we're going to do is we're going to start talking about the Chargemaster. Now, I used to talk about these as two separate items, your Chargemaster and pricing transparency, because I thought, pricing transparency, it's going to go away. Really doesn't matter anymore. Yeah, I was wrong. Pricing transparency, it is together. The pricing transparency and your charge master, the two do live together. So I want to just talk about some foundational items of your charge master to make sure that you have the CPT HCPCS code that tells the services that are being done, the appropriate revenue code. This is one of those, it's a 3-digit code. Some of your systems may call it a subcategory, may call it a department code, and things like that. This is a revenue code that actually tells the payers where this information, where the department that these services related to. Was it in an ER? Because you can have a procedure that's done in the ER and also a procedure that's done in a treatment room. And the revenue code helps distinguish for the payers where that location was performed. And then the price of the test. The price doesn't always equal cost. It's the price that you are charging to the payers. So you have the services, again, CPT code, translated into billing codes, where the services were provided. If you have an RHC or a federally qualified health center, that code is like an 052, just to give you an example. And then the charge for the procedure themselves. So those are the things that you want to make sure are foundational items in your charge master. Now, when looking at your charge master and best practices, there are four key areas that you want to look at. Those key areas are where you can look at charges that are missing CPT HCPCS codes. And a lot of times, what I have seen in working with hospitals is that you have the OR, and the OR will say, okay, we think this procedure is done, but we let HIM process that. HIM will then add in not only the diagnosis codes, but they will add in the CPT and HCPCS code to say that it wasn't just a colonoscopy that was done, but it was a colonoscopy with biopsies removed. And so, there are times though that you want to have missing, that you will have charge codes that don't have a CPT HCPCS code, but most of the time, best practice is that you want to make sure that they do have a charge code on there, because anytime that there's not, when it makes it through, you're going to make sure when it's the claim drops and it starts going through the process, it could get hung up in different places and need manual intervention. And manual intervention means that there will be a delay in getting the payment back to your hospital. It'll add another step in the process to prevent the automation of the payment. The other area you want to look at when looking for your charge master is looking at any charges that are below your Medicare fee schedule. As I shared before, the Medicare fee schedule is what Medicare has assigned as being the cost to perform those tests. And so you want to make sure that you are leveraging the costs, or that you are leveraging this Medicare fee schedule to the best opportunity, and that you're pricing for at least one time the same amount of the Medicare fee schedule, if not more than that. And when looking at these prices that are assigned to it, most payers, they're not going to push back if you have it priced at a Medicare fee schedule. They may push back if you have it priced at, say, 8 or 9 times that Medicare fee, but they're really not going to give you any pushback if you only have it priced at one time. And then a lot of places haven't gone through and looked at their charge master in years, and it could be that the Medicare rates have gone up, and you need to make sure that that's accounted for in your pricing strategy. The other area to look at is the invalid CPT HCPCS codes. This is where the CDM records in your Chargemaster have CPT and HCPCS codes that are no longer listed on AMA or on the CMS data files. Now, with these invalid codes, every year in January 1st, or prior to January 1st, they've announced which codes will be updated in January and will no longer be active. There were 405 codes that were updated in 2022. So you're going to want to go through. Now, that was updated. They could have been added, deleted, or modified in some way, revised. So you're going to want to go back and look at your charge codes and see, do you have invalid records? Because what I will tell you is one of three things is going to happen. One, the payer, you're going to put that charge through and it will get caught at your clearinghouse, and your clearinghouse is going to send it back to you and tell you, hey, you got to fix this because we're not going to send an invalid code onto the payer. So that's the first thing that's going to happen. Second thing that could happen is that it makes it all the way through the process, and then the payer gets it and they send back a rejection that says, hey, we're not going to process this claim because this code is invalid. So you need to fix it because we're not going to process your claim. So in either instance, you're not getting paid. The third thing that's going to happen, and I think this is what happens the most time, is that it makes it all the way through and the payer goes, oh, look, they used an invalid code. And with that invalid code, yeah, we're not going to pay them. And they just don't pay you. They don't deny the claim, they deny the line item, and you don't receive payment for that line item. And depending on the volume that you have going through your back end, working this denial management and denials resolution, it could be that claim never gets touched. So when it's an invalid CPT HCPCS code, you've provided the service, three things are going to happen. It's going to not make it through the clearinghouse. Somebody's going to have to touch it. It's not going to make it to the payer. Somebody's going to have to touch it. Or it's going to make it to the payer. And in all three instances, you're not going to get paid. So, you did the service. It's just somebody's using an invalid CPT code that needs to be fixed. And that's where you want to pay attention to those items. And then the final item to look at with a charge master or where you have the same CPT HCPCS code out there. It's being used in two different areas. Like a minute ago, I mentioned you could have the same CPT code in both the ER and in a treatment room, like a wound care visit. The one I've seen and I've talked about a lot, if you've talked to me before, I've probably referenced this, is like with PT and OT. In physical therapy and in occupational therapy, they both have a hot cold pack. It has a CPT code assigned to it. But I've seen hospitals where in the PT department, it was priced at $25, and in the OT department, it was priced at $10. And so it's the same hot cold pack. They got it from the same supplies. It's the same supply, probably in the same box because the two departments are next to each other. So they go get that same hot cold pack, but they're charging two different prices. Now, why do I bring this up? Because if the patient has always been coming in and they're going to the OT department, they get this hot cold pack for $10, $10, $10, and then all of a sudden they don't get it from the person that codes it in, doesn't code in the OT code, they code in the PT code, and it's $25. That's going to be a phone call. And that's probably going to be a phone call to the CEO to go, I've been coming here for months. And when I've been coming here for months, I always get charged $10. Why am I now getting charged $25 for it? Or $45 for it, whatever the difference is. And it's not just that a hot cold pack, it could be lab tests that they come in. Um, they're having their test run in the lab. They come in on a monthly basis for the past 10 months. It's this. They went in a different door of your hospital and had it done there, and it's a different price. And so those are things that just really patients see it, and you want it, it's an easy fix. You can just run a report out there to make sure that when your services are assigned at the different price, that maybe they need to be assigned the same price. Or it could be as well, there are exceptions to that, to where it's like, yes, ma'am, that is indeed the case. You need to, we do have that priced at different rates because you're at the rural health clinic that's down the street, and we have to transport that you know, vial of blood to the hospital to have it processed, and it's more expensive. There are additional expenses related to transporting that to the hospital to have it run. So those are just things to keep in mind when looking at your Chargemaster and best practices related to it and why it's important to look at that. The next area in looking at your Chargemaster is, do you have a defensible pricing strategy? Do you have a strategy established for how you set up pricing? And then what does that look like? When was the last time you did an entire Chargemaster review? Have you done that? Looking at an ongoing practice as well for establishing new procedures that engages both the operations department and the revenue cycle teams. Is how you're pricing this set up, and is it defensible, and are you protecting it? Because in the world of pricing transparency, where your charge master is out there and published, you know, the they're going to be looking at your information and go, why do you charge 15 times more for this, a CT of the brain than you do for the CT of the brain with contrast? Those questions they're going to start asking. And so, you want to make sure that you're looking at that and and addressing them ahead of time and preventing those questions from coming through. Because a lot of these best practices, what we're doing is just saying, if you address it up front, it's going to save a lot of problems down the line. So when you think back to the chart we were talking about, if you address these pre-claim services before the patient ever thinks about coming in the door and you're addressing it, it's saving a lot of time on the back end. And then when talking about pricing transparency, so you have your shoppable services and you're posting that information out there. There is an annual maintenance. CMS requires that you update it annually. And so you're going to need to go through and update pricing transparency on an annual basis. You can easily tie that into a CDM review. How are you doing it? What does that look like? You want to look at changes in when you're doing pricing transparency, any changes in standard charges. Did you do a price increase? Because you definitely don't want a price that the test is $15 out there and have done a pricing increase and the patient gets a bill for 17. Those are the things you're going to want to look at. And then also looking at, what is the marketing need? Can you leverage the shoppable services that are out there to provide for the marketing need and the marketing strategy? Can you leverage that? It's okay to go out to the community and go, look, check us out. These 300 services, you can go to our 5 competitors and look at it, see what they charge. We charge less, and we use the same machines. We use the same technology. It's the same, and we are a higher quality provider of these services. So why not come to us? And then I did add in here surprise billing with part of pricing transparency, because now with the surprise billing, good faith estimates are required to be given to any self-pay patients and any self-pay and uninsured patients who register for services at least 3 days in advance. So you're having to share this information, the information that's on your Chargemaster and the prices that you are charging and what the expected reimbursement amounts are. You are having to share that with your patients now. It's required from CMS as of January 1st of 2022. So it's a good thing, of this best practice, to make sure that you are reviewing your charges and that they aren't out of bounds, and that the information that you're providing to your patients is good information that they can rely upon. And then, because I know that some of you are with critical access hospitals, um, we just want to show that they're interdependent with each other. That when you are updating your shoppable services and your payer contracts and your CDM pricing, that there is still that cost report impact. That you can't look at it in a vacuum. That you're going to need to manage all of those together. That if you change some of your payer contracting and change prices, even lowering them or raising them or including different services on shoppable services. What are you doing in cost reporting? And I always show this as a circle, and I say to people, leave it as a circle where they're all interdependent upon each other and they're all the same size. Don't turn it into an amoeba where cost reporting is real little bitty and you've only focused on shoppable services or you've only focused on payer contracting. You want to make sure that they are all tied together, because changing one is going to change any of the three of them. Even changing cost reporting, you're like, really? Is that going to impact it? It's like, yes, changing the cost reporting will impact your payer contracts in some instances, because your Medicare Advantage plans are going to be following along with what Medicare rates are. So you want to just keep that in mind and make sure that you are paying attention to it. So now we really talked about the front end with the pre-claim activities. We're going to talk about analytics. And what I want to talk about with analytics is, in order to measure it, you have to manage it. And in order to manage it, you've got to measure it. But in order to manage it, you need to define what you're looking for. And you want to make sure that you're addressing where the challenges are. So again, we've got different analytics, and really what I'm going to talk about now is just about your data. We'll talk about some of these key metrics here in a minute, but first I want to talk about your data. How clean is it? Because, without clean and meaningful data, you're gonna have a problem. Now, why do I say that? Well, inconsistent data that doesn't reconcile, there are going to be problems with that. Someone's going to sit around the table and go, well, my report says 400. Another one's going to say, well, my report says 4,000 units were processed. And then you spend all time addressing the inconsistent data as opposed to addressing the problem that's arisen. Without clean data and meaningful data, no one understands the why. Why is this going on? What's happening? Nobody knows, because they don't understand the report. And when they don't understand the report, they get the email every day. But you know what? Engagement's not there. Everybody can get an email, but if they're not opening the email and reading the email, then you have missing team engagement. And with missing team engagement, you end up with blind decision making. They're just, we're making decisions. We're not really referring to any situation that's there, any situation that is there in any factual data, that you're just making a decision willy-nilly. And then you also run into the situation where you're missing opportunities to make change. That had you been looking at the data, you could have caught it earlier. And so, really, what we want to say is, without clean, meaningful data, small problems can lead to costly situations. So when you think about it, with small problems, you have team engagement. No one understands the why, and inconsistent data doesn't reconcile. But the big problem is that you have missed opportunities to make the change, or you're just blind decision making. And really, when you think about it, I wanted to give you an example of this, right? So when you have a small problem, staffing metrics aren't monitored, right? No one notices that the coding department needs additional FTE based on current volumes. We're just not looking at the staffing report. That's a small problem. Okay, no big deal. It's just the medical record department, or coding department. Not a big deal. We don't have to worry about that. Or do you? Because over time, what this leads is to an erosion of culture. And that's exhibited through turnover. That coding department, they know they're understaffed, they're overworked. I'll just go work for this employer who lets me work from home, and I just do it remotely. I don't even need to move. I don't have to do anything like that. I don't mind. Or you have a lack of provider and team engagement, that the coders aren't telling the providers where there are problems that they're seeing. They're just not engaged. Oh, whatever, I'll do it this way, go on. But what happens though is that, okay, small problem. You didn't look at the staffing metric. That led to just a culture problem or turnover or just lack of engagement between the team and the provider. But the costly situation is that the training breaks down and key elements are missed, which could result in a potential Medicare false claim. Now, at that point, if I were to start and say, you could have a Medicare false claim if you had, you know, you could have, here's how you prevent Medicare false claims. Everybody pays attention to that because that's the big problem. No one wants a Medicare false claim to come across their desk, right? But they really could have prevented it if they had addressed the small problem in the beginning, which was no one noticed that the coding department needed an additional FTE based on the current volumes of the facility. They were busy looking at other things. And so that's why you want to make sure that you have clean and meaningful data and that you're really paying attention to it and that you're not distracted by, oh, I really don't know if this is good data or not, but it's meaningful to the department and people are having discussions about it. And so when you have clean and meaningful data, you know, actions happen, that reporting is replicated on a standard cadence, that this is a roadmap. It's a roadmap of where we're headed, that every day they know that, look, there's a mile marker, there's another mile marker, there's another one, here's a report. Oh, here's my weekly report. Here's my weekly report. And they start looking at the volume and making sure that there's a standard cadence there. That's what your best practice should be in looking at it. And then also, when you have a standard cadence, you have one version of the truth. One version. Everyone is provided this consistent version, a consistent roadmap to follow. They know the direction that they are headed, and the focus shifts to addressing the problem rather than questioning the data. What's the problem that we need to address? We need to address staffing rather than, are you sure this report is right? Do we have the right number of accounts? Is it correct? I mean, which one's better? You get things done faster when you are addressing a problem. And problems are identified quicker, that you're not waiting for the Medicare. In order to get a Medicare False Claims Act, there had to have been several claims that went through with the wrong information on it, right? Wasn't just one or two. And so you're identifying those problems quicker. And then you can also identify utilization and throughput, and you can assess it and actually look and say, we need to put this coder in there, or we did put the coder in there and look at these 5 things that new coder has allowed us to catch, or they put a new coder in there and look what the manager was able to do and find and communicate that message to the provider. And then also short and long-term efficiency improvements, that you start seeing it, you start seeing the team become more efficient, and or not just the team, but you can see whatever your problem was that you're addressing with this meaningful data. You start making these short-term improvements, and after a while, short-term improvements turn to long-term efficiencies. And then you also have it in engagement across all departments. When they start talking about the same one version of the truth, they're all talking about it, and then they can all refer back to the same department, and the provider is talking about something that the clinical team is talking about, that revenue cycle is talking about. So you want to make sure that you have clean and meaningful data to present. So when looking at this, what I want to do is I go to my next page and you see all these $100 bills, they're flying around because there are really some key indicators that you can use to monitor your revenue cycle performance. And so we talked about we've got clean data. So now when we talk about the clean data, let's talk about some reports that we can use to track it. Now, I do refer back to HFMA because they have created a MAP Key Initiative. And the MAP Key, what that stands for is that they measure performance, they apply evidence based improvement strategies to perform the highest standards. And so there are five major categories: it's patient access, pre billing, claims, account resolution, and financial management. And there are 29 different benchmarks. And if you want more information, I've given you a link to the HFMA website to go look at the map keys. They actually have a competition every year to see who is the highest performer. And on that page, they actually give you, the highest performer in each categories, whether it's um, a large system based, or, excuse me for a minute, whether it's a university based system, whether it's a small critical access or provider based. Excuse me. I apologize for that, but they give you different standards that you can use to compare yourself to. And so we're going to go to the next page. The next page just talks about the key areas that they are looking for account resolution. I'm going to pause for a minute and let you read over these to see for, for reports that they track for account resolution and patient access.
And this might be a good time as well while you folks are reading through those and giving Amy's voice a rest here. If anybody has any questions on the content so far or any comments, please feel free to unmute yourselves and chime in. Otherwise, the chat box we're monitoring as well. Anyone who called in, it's *6 to unmute your line.
Thanks, Shannon, for that. I should have warned everyone ahead of time that I have been struggling with a sore throat all week and just I was afraid I wasn't going to make it, and that happened. So thanks for catching me there. So I'm giving you these. So we have the account resolution, the patient access. I'll go to the next page and show you financial management, pre-billing, and claims. Now, again, as I said, there were 29 of them out there. And with the 29 that are out there, sometimes you're like, I don't have any. Where do I start? So, what I wanted to do is I've taken those and actually giving you some key ones that you can focus on and key information. So really, the reports to do it when thinking back to that, let's all get on the same page. The claim life cycle, you have claim life cycle process measures, how you manage your clinic AR, how your hospital is performing, what does that look like? And then you also have financial manager measures. How is your clinic, your department performing financially related to the accounts receivable? And so what I'm going to do is actually separate that and tell you some process managers, break it down into some you know, more manageable, pulling out the key ones that I would say you want to, at least at a minimum, have these reports out there and work through them. So when thinking about process measures, this is where you're coming in pre-claim through the front end. And when you think about this, clean claims rate, these are the number of claims that pass through requiring no manual intervention. Boom, claim gets entered, all the clinical information is done, it's coded, all the way through, clean claim rate. How does that work? When we were talking about earlier with invalid CDM and the invalid CPT codes, that this is where you will see if you've got problems with your invalid CPT codes. It won't be a clean claim. Or if you're missing a CPT code, it's going to require manual intervention before that can be done. Point of service cash collections. This is so important. Back in the day, and in the next webinar, I'll really talk about this more, but back in the day, we really didn't care. We didn't focus so much energy and attention on cash collections. But now that people have a high deductible health plan, this is really key. What are you doing at the point of service to start getting that cash collection in? Because people will need to be paying for those services. Denial write-offs as a percent of net revenue. What are your denials looking like? If you have denials that are relating to provider not found, that's because the provider wasn't found. It missed out on that provider registration and the EDI enrollment and the banking setup and the EFT ERAs. They're telling you right there, we've got a problem. So, what is your denial looking like? And then also with self pay patients who are receiving financial counseling and education. I actually had pulled this information before, and I'm interested to see if um, HFMA is going to update the self-pay patients receiving financial counseling and education to also including good faith estimates. Now that that went into effect on January 1st, 2022, that's something you're going to want to monitor because you don't want CMS coming in and going, "Well, show me your good faith estimate process," and you'll be like, "I didn't know that existed." That's something you're going to need to have. And, if you have a group or an individual who does education on the financial counseling, that you want to also include in that good faith effort. But what you're going to want to make sure though is that you're measuring it, that you're actually tracking to monitor. Because we can easily call and say to somebody, "Hey, do you have that process going on?" And they'll be like, "Oh yeah, sure, sure, not a problem." But if you actually ask them to tell you how many patients were self-pay, and of those patients were self-pay, how many, not just how many, who were self-pay patients, and did they receive financial counseling? Which ones received financial counseling? By monitoring that on a regular basis, then you will be able to make sure that you're in line. And it's that small problem, making sure you're addressing it early to making it all the way through. And then looking at financial measures, how to monitor your revenue cycle health. This is with transaction processing and AR management. You want to look at net days in AR. And you can look at gross days. A lot of times I look at net days if the system will do it. So it really depends upon your accounts receivable system that you may do net days in AR or gross days in AR, just depending on how your contractuals are recorded. So I will put that one caveat out there. And then what you want to look at is accounts receivable as a percent, greater than 90 days as a percent of the total AR. What is that looking like? I will say I looked at someone's report the other day and I looked at their Medicare, and over 70% of their Medicare business was greater than 90 days old. Or no, it's probably like 50% was greater than 90 days old, and 70% was greater than 60 days old. And I don't know about you, but that's a problem. Medicare pays in 15 days. So if Medicare pays in 15 days, then why do you have anything greater than 60 days old? Because maybe between 30 and 60, you're appealing it and denying it. And you may have little bitty claims out there, but not 70% of your AR greater than 90 days old. I mean, greater than 60 days old. So those are things that reports like this actually help you look at. And then, days in total discharge but not submitted to the payer. This is a key area to look at because you know what? If you haven't sent it to the payer, you're not going to get the cash. It's like there's no opportunity to get paid if you haven't sent them a bill yet. And it really sounds pretty simple, but you know, it's one of those things that a lot of times we don't track, and no one cares to look at. Well, how much money's tied up in what we would call unbilled. You might hear it called DNFB, days final uh, discharge, not final billed, things like that. And also look at cash collections as a percent of your net patient service revenue. What are your cash collections looking like? Bad debt as a percent of net revenue, and charity write-offs as a percent of net revenue. These are key measures to look at. Bad debt. If your bad debt looks like it's out of control, are there things that need to be addressed earlier in the process? Is something broken that, yeah, I will tell you, bad debt as a percent of net revenue. When we were talking before about how, if you don't put that invalid CPT code, it makes it all the way through. Yeah, this is where it's going to show up because all of a sudden your bad debt's going to start going up because you're not getting paid on those claims. So those are things to really keep in mind for looking at the financial. This is the financial health of your accounts receivable. Whereas if we go back that one slide, the process is, the health of how your process is working. Is your front end, is your registration process really working correctly? Or do you have something broken there? And so, okay, I've told you all of this, and you're like, okay, Amy, I get these reports, but how do I spot trends and anomalies? How do I know something's wrong there? Well, one of the ways to do it is to establish a reporting cadence, daily, weekly, monthly, and quarterly. And what you want to do is you want to make sure that there are certain items like unbilled receivables, they're daily. They only happen that day. Unapplied cash, it's only as good as the minute you run that report. Because if you've got a payment poster who's posting cash, that unapplied cash now has gone down, right? Or if you get a deposit in the bank, the unapplied cash number has now gone up. So you want to establish a reporting cadence and make sure that you're following that cadence and you want to stick to that. Some of these reports, like unapplied cash, can't really be reproduced, or unbilled receivables, they can't be reproduced. Whereas other items like your AR report, I mean, maybe you only want to run your AR report on a monthly basis because there's so much activity with the ends of the new charges coming in and the payments being received that really only looking at it on a monthly basis is appropriate. And so, establish those baselines, establish that reporting cadence, and then work from there. And then, really, what you want to do is just start looking at, your baselines. What you want to do is compare a period against another period. So, in this instance, your current period versus the prior period. So, in this example, I'm looking at January, we're in the month of February 2020, and I was looking at how many days are in accounts receivable, and accounts receivable is greater than AR, it's at 13%. Days discharged not submitted to payer. Cash collections as a percent of net patient service revenue has gone down. Bad debt and charity write-offs. And so I may look at this and go, ooh, I got a problem. It was a 15% decrease in my cash collections January to February, right? But if I look at the current period versus the prior year, I look at this and I see, oh, maybe not so bad because I'm actually collecting more cash than I did this time last year. And so it looks like January was a higher collection month. And when I think about it, maybe that we've worked with the front end staff and the front end staff is aware that all of your deductibles start over or not all of it, maybe 90% of deductibles will start over with the calendar year, their calendar year deductibles. And so we've worked with the team to get that front end collections up. And so you can see that, yes, it went down from January because they were getting all the deductibles in January. And it's still, they are doing a great job because they were able to increase over last year. But then when you want to look at your prior year end, what happened over the prior year end? And you can see that based on this one actually had a December 31st year end. And so you can see it's still up from the end of the year. But you might want to look at your bad debt because in all instances, so we were focusing on cash in all instances, bad debt's going up. It went up in January. It's over 2022. Not 2022, it's over the prior year. And then at the bottom, you can see it's even up from December. So instead of cash collections on first blush, thinking that's where our problem is, that when you look at all three of those together, that it may be a different factor that's in place, or, may have something to do with just old receivables. So, what does that look like? And looking at them. So, in looking at trends and anomalies, just have a baseline. You have your current period, but then compare it to what happened last month, what happened last year, and what happened at the end of the fiscal year, and working through that to see where your shifts are, because you can actually see that, and net days in AR is also going up. So there was a change there. So those are things to just keep in mind, that the different reports will help you get a more well-rounded picture of what's taking place in your accounts receivable. And so when this happens, what you're going to want to do is ask questions. And you want to ask Who's working it? What's going on? When did this happen? Where's the problem? Why is this occurring and how? And then I'd say, but you want to ask why 3 times because you know what? Why is this happening? Well, such and such couldn't work on it. Well, why could they not work on it? Well, they were out with COVID for a week. Well, why didn't we have anybody as their backup? We don't have enough staff to train to be, trained in both departments. So it could be that it's not the problem that somebody didn't work it, it's that the problem is we didn't have the backup. So those are some of the answers. Or it could be, aging buckets. Is there a bucket that's increasing? Is there a bucket that's decreasing? Is there a specific payer that stands out? Is this an annual trend for the payer? Now, some of you may be in Illinois, and when I say you're in Illinois, it'd be like, Illinois, they stopped paying claims in about September, or maybe no, they actually stopped paying around July, August, and you just know for the payer in Illinois, my AR is going to grow because the fiscal year starts in October. And so, state of Illinois, any Illinois Medicaid claims, they're just going to grow. They're going to grow in July. They're going to grow in August. They're going to grow in September. But then in October, we start getting paid again. And so the AR comes down. So you want to look at it differently and just say, and when people are asking about the aging buckets and you have Medicaid, state Medicaid with Illinois, or even your state may do the same type of thing, but it's very interesting. I've worked with several different organizations and we all had problems with the state of Illinois growing in that July through October timeframe. But you're going to get paid, so it's working out. But then don't just focus on financial areas. You want to look at the entire process to make sure that you've identified the root cause. Have there been operational changes? Is someone that was in that role doing that job is now retired, and we don't have anyone? And then also understand that the first answer isn't always the only answer. That there are multiple factors which play into it, which can give you multiple answers. And that's why it goes back to asking the questions and making sure that you're not just getting the first answer, but that you're getting the complete answer. And so then that just gets us to the end of it, the foundational items of just revenue cycle, where you're focusing on pre-claim activities because they're going to flow through all the way through. They're going to touch every single area on, and then analytics, how to make sure that your processes are working correctly. And then so for our next webinar, what we're going to focus on is on these front end activities of pre-visit and visit. And then the third webinar, we'll be doing the transaction processing and back end. So that gets me to the end of it. I see we've got about 3 minutes left, and Shannon, I will hand it back over to you to see if there are any questions that people may have.
Yeah, excellent. Thank you so much for the great session, Amy. And please feel free to chat in any questions you have for her. But before the end of the session today, please take a moment to complete some post-polling questions. Caleb will be pulling those up for us. And while you're doing that, I'd like to just provide a reminder about the CEUs that are available through the American College of Healthcare Executives. A link will be sent following the 3-part series to indicate you'd like that ACHE credit, so keep an eye out for that. The slides and the webinar recording will be made available on our website very soon. Those will be emailed out to you folks as well. And then as Amy indicated, our next session is going to focus on front-end revenue cycle best practices. So we encourage you to invite any of your team members who might be able to benefit from that content, but those sessions will be recorded as well. And that will take place at 11 Central on Tuesday. So we look forward to seeing you then. And I think I see a question. They say very well presented and greatly appreciated.
Thank you very much. And thanks for your patience with my voice going out. Hopefully by Tuesday it will have recovered even more. My contact information is here. If you have any additional questions, you can send it to me or through Shannon, whichever you would like to do. And then there are also additional resources that have been provided, links to the different areas on different best practices, clinical documentation and integrity, 340B, and things like that. So wanted to also provide that information to you as well.
Well, that's excellent. Thank you, Amy, so much for your time, and I hope you all have a great weekend.
Thank you. You too.
Thanks. Bye-bye.